I'll kick off with a question, though, to each person, just to make sure we get their perspective on where they stand on this issue of addressing key research gaps. And I'm going to start with Dr. de-Graft Aikins, who's a visiting fellow at the London School of Economics and an associate professor at the University of Ghana. We had spoken on the phone while she was in traffic in Accra, and I was having lunch in Georgetown. I said, we're really global here. She's a social psychologist specializing in chronic physical and mental illness among African communities and spends a significant amount of time in the field. So we're glad to have her here with us as well. And I'm going to kick off with that question to you on where you see the gaps existing and where does the focus need to be. I know you're particularly concerned with the need to look more effectively at the categories of disease.
Yeah, I think that we need to be looking at the way in which the chronic disease burden affects not just low and middle income countries, but also within low and middle income countries, how it affects the poorest communities. Because what we're seeing now is that if you look, for instance, at urban slums, poor rural areas, these communities tend to have a higher burden of chronic diseases as well as mental health conditions. It brings up the issues around comorbidities, where we might have the coexistence of infectious and chronic diseases within households, but as well as within individuals, where we might have comorbid conditions of say, people having diabetes and hypertension at the same time, as well as depression. It segues into the healthcare implications. Medicines, food, lifestyle modifications are the key things we need to be looking at. Medicines being the heart of the problem for many people who live with chronic conditions in these societies. And usually we talk about sort of availability, access, equitable distribution, and affordability. But when the research I've done, for instance, looking at Ghanaians who live with diabetes in Ghana and in Europe, suggests that we need to be looking at how people manage comorbid conditions. For instance, if you've got diabetes and hypertension, how do you reorient yourself to the fact that you live with two conditions, which has two separate sort of medical strategies you need to employ, and how you even make sense of the medicines you take. Most rural people in Ghana, for instance, do not know the medicines they take. They don't know the medicines by name. When they get tired of taking the medicines, they might decide to take half a pill, a quarter of a pill, or not take anything at all. And finally, it also means that we need to be looking at prescriber training. What we've learned from our research in Ghana, in Cameroon, in Kenya, and so on, is that often doctors, as we all know, are not pharmacologists. Neither are they pharmaceutical experts. I mean, they learn, like all of us, from the pharmaceutical industries. And so we need to understand how doctors actually make sense of pharmacy, pharmacology, and the right medicines for people in places where resources are very constrained. I'm sure I've spoken to the other panelists, and the issue about task shifting, trying to train lower skilled workers to understand prescribing habits and medical care also becomes very important. So I'll just throw out these ideas for now.
And actually it's interesting because I know you also have the complication of faith healers coming into the picture, you have religion coming, and we'll touch on those issues as the debate goes on, because it's a much more complex scene on the ground. So thank you very much for that, Dr. Aikins. Francis Gurry, great to have you with us too. As Director General of the World Intellectual Property Organization, I know you have a challenging job there because you have to consider how global markets throw up so many challenges in the issue of IP regulations and protections, which of course is an issue that's critical in order to secure the integrity of innovative ideas. So I'm wondering where do you see the role of the international community in facilitating innovation where there are perhaps limited market drivers?
Yes, well, good morning, ladies and gentlemen. Thank you, Rhys. Well, I think that it's an area, as Sir George Allen said last night, which requires some social innovation or some organizational innovation. I think, in a word, what I would say is platforms rather than treaties. In this area, if we want to encourage the capacity to innovate in areas where the market is failing, then we need to use different forms of organization in order to do so. So let me refer to one example of that, which is WIPO Research, which just celebrated its first anniversary. And I mention it, first of all, to thank all of the members of PhRMA who have joined it. There are 61 members after 1 year. 10 collaborations have been signed and are underway under this. its aim is to accelerate drug discovery, and of course that's a long, long path, and the pathway to get there is capacity building. So we're seeing in these collaborations the sharing of intellectual property, the sharing of data, scientific data, unpublished data. And why can companies and research institutions do this? They can do it essentially because they're doing it in an area in which there is no market. And in which the ordinary market incentives are not operating. So it's possible for them to do things in that area which they may not be able to do in areas where they have direct competitors and markets. And we think it's taking advantage of the networked world. It's using that form of organization very much. And it's focused and concentrated and will deliver real capacity building with scientists moving around from institution to institution. Now, it's a very large question, market failure, of course, and there are many dimensions of it, but that's one example, I think, where we can see a different form of organization which is going to make a good contribution.
Thank you, and I will look at how emerging markets perhaps complicate the picture as well as we get into the debate. Dr. Trevor Mundel, good to have you with us as well, sir. President of the Global Health Program of the Bill and Melinda Gates Foundation, an organization with a huge amount of respect for its healthcare efforts worldwide. Now, of course, you lead the efforts in research and development of a number of essential health solutions. To what degree is innovation a contradictory term? I mean, that's to say, you know, is it necessary to use such expressions when the priority is perhaps to simply get what's there already out to the people who need it?
Because that's a question that I frequently get, actually. Why don't we just go out and deliver the many good therapies that we have to the people that don't have access? So it's just really an access and delivery issue. Why have the portfolio? And I take that very seriously, actually. If we can maybe pull up that little picture that I brought along today that I thought people might be interested in having a look at.
Once we get the slide up, you can refer to it as well.
Yeah. So as we're looking at the options that we have in terms of innovative new therapies in the R&D portfolio, and people may be familiar with this type of depiction of a portfolio which we've been looking at, except the axis is a little bit different over here to some of those that you might be thinking about. We're thinking about how much it costs to avert effectively death and disability, and then what is the likelihood that we'd actually be able to achieve that. So you can see the very rich innovation portfolio that we actually have in the global health space. But what we've been careful to do is to put there the very practical interventions. Male surgical circumcision prevents about 60% of transmission events in relation to HIV/AIDS. Bed nets, highly effective, cost-effective intervention in preventing malaria, severe malaria cases. So we position these very practical interventions against the innovation portfolio. And what we say to our folks and to the proposers of new innovations, prove to us that our investment in your innovation is going to be better than buying a family a third bed net or investing more heavily in male surgical circumcision.
Do you get resistance when you set benchmarks like this?
We do. But I think that in terms of, having to make some choices, having a constrained budget for the whole the global health portfolio, it's essential that we can point people to, it's interesting to do these things. We like to innovate, we like to invent new things, work out in the field, but that's not the intention. The final intention is the outcome and the impact we're going to have. So as much as it's interesting and nice to do these innovative ideas, let's put that against what practically is going to be impactful at the end of the day.
Real results. Okay, we'll touch more on that as we get on with the discussion as well. I want to introduce Dr. Dhaval Patel, who's the head of the Novartis Institute for BioMedical Research in Europe, as well as global head of the autoimmunity, transplantation, and inflammation disease area, where he's responsible for managing all of the drug discovery groups in Europe with a focus on immune-mediated diseases. So welcome, good to have you with us too. Why is it perceived by that many big pharmaceuticals don't work on neglected diseases, do you think?
Well, that's a very good question, and certainly the industry seems to have a bad reputation in this regard. I think we'll hear from the other panelists that that's probably not necessarily the case. And to me, neglected diseases, we talk about malaria and others like leprosy, they're not really neglected. We do work on them. And in fact, for Novartis, we have probably the best drug for malaria today, Coartem. And of course, it doesn't stop there. I've heard from this particular panel and the previous one that access and how patients take medicines is also very important. This is a place for innovation. For malaria, for instance, Coartem, we have to give over a 3-day course. There's a lot of hoarding going on. So if a patient gets a pack of 3 pills, they'll take the 1 pill, feel better, and then save the other 2 for later. Of course, that causes resistance and other issues. And so the next wave drug that our group in Singapore, the Novartis Institutes for Tropical Diseases, has developed has the potential to be a single dose. And it is this type of innovation that I think we can continue to address all of the unmet needs that are out there.
So you're having to adjust your drugs to suit the lack of compliance that you're facing out in the field. But let me ask you, just as a follow-up, how Novartis uses its resources to innovate when we're looking at creative innovation and the gaps in research.
Certainly, we couldn't provide innovation for the developing world if we didn't have resources. And the resources, of course, come from the developed world. We try to have institutes, for example, the NITD in Singapore, which is solely dedicated to tropical diseases. We also have the Novartis Vaccines for Global Health, which is for making vaccines for sub-Saharan Africa and diarrheal diseases. These are not standalone. Even though we have these standalone entities that are funded to the tune of tens of millions of dollars a year, those are supported, in fact, by our entire infrastructure and activities. So they could not exist without the support from the rest of the organization. So we try to leverage what we have.
Excellent, thank you. Dr. Bernard Pécoul, good to have you with us as well, sir. You're the Executive Director for the Drugs for Neglected Diseases Initiative, DNDi, an effort that Dr. Pécoul has been leading since its founding in 2003. It's a not-for-profit research and development organization that's achieved some amazing results, which I'm sure we'll get to hear about. And I want to start off with you by asking, what has been the main change you've seen in the past 5 years? I mean, since you last spoke to the conference on this issue of creative innovation and the gaps, how much have things really moved?
Thank you. In fact, I will go back to 10 years ago, because 10 years ago, the perspective to develop new treatment or new product for neglected disease were very little. In fact, we assessed the pipeline at that time. The pipeline was almost empty. So this situation has started to change because of many different players. I will mention, of course, the product development partnership. So it's a group of entities that have been set up mainly during the last 10 years, and DNDi is one of them. Have started to change a little bit the dynamic, involving partners from public and private sector to deliver drugs. And today, after 10 years of existence, DNDi developed 6 new treatments, and we have in a portfolio a dozen of products that could enter into development and then being available. But I think we still have a major challenge in front of us, and I would like just to bring 4 issues that could be important if we want to make progress in the coming years. One is concerning boosting innovation. And here I will refer to the meeting. In fact, 6 years ago, I was invited at a meeting of IFPMA. And my main message was to say we need to have access to compounds library. So we need to have access to your expertise, to your knowledge on the discovery side in order to be able to select new candidates. So at that time, we have an agreement with 3 to 4 companies. And today, I'm happy to say that we have ongoing agreement with 20. But of course, I will ask for more. I think the next step is now we need to be innovative on the way we challenge this issue. So here, I consider that we have to move into more open innovation. We cannot lose time. We need to save the limited resources that we have. We have to bring people together, partner together, to get the best from the different partners in order to improve the productivity of this innovation part. And the second aspect, and it's something that we are very careful when we negotiate a contract. We need to think access from the beginning. So we need to secure the guarantee that at the end of the day, if we are successful, we'll have a product that will be accessible at an affordable price. And it's typically, I think we are also making some progress because recent agreement that we have signed, for example, with Astelias, is including this characteristic from the beginning when we have access to the component library. The second ask, because I have a second wish coming from the company, we need more partnership for the development part. Not to implement the clinical study, because here I think we set up with endemic country very solid platform to do the clinical study, but we need partners to be involved on a manufacturing, on a registration, on a distribution, and so securing the sustainability of the product. So today we have few examples of success on this side, but there is not enough. So I invite the company to join on this aspect. And just the two other elements that will not develop, but I will mention at this point, I think it's key to involve endemic countries from the beginning in all this story, from A to Z. So for the definition of needs, as well until the end when we are implementation. Because at the end, they will have the responsibility to change the environment. And the last point is that we have some success, but those successes will suffer if we are not capable to create a sustainable environment. So sustainable environment, of course, is on a financial side. We need new source of funding in a sustainable way, but also it's on a regulatory side. We need a framework that will stimulate this research on a long term, with a group that need to set up priority, and according to me, WHO is in the best position to set up priorities.
Thank you, Dr. Pécoul, and of course you've raised some interesting points. We will get into the debate as well. I'd like to welcome in here Ulf Wiinberg, who's the President and CEO of H. Lundbeck Pharmaceuticals, a responsibility he's had since June of 2008, prior to which you were 27 years at Wyeth, and working at the American Medical Corporation in a number of senior global executive roles. Now, I want to ask you to what extent do budget constraints make it challenging for the pharmaceutical industry to innovate?
I think clearly there are general pressures on the industry right now and more uncertainty, and it means that it's more important to pick safer projects and know earlier if they're going to work, and that very much handicaps our area with research in the brain. We heard in the previous session how difficult it is to do research in the brain, lack of biomarkers and clinical markers, and what we are seeing now. I can give an example comparing with cancer. The first monoclonal antibody came in 1973, and it took 25 years to start to have an impact in cancer. And the last 10 years has been tremendous in terms of development. When we look at CNS, we have a phase 1 Parkinson candidate for personalized medicine. But I cannot say it's immediately around the corner that we will see personalized medicine within mental health diseases. And so clearly it's important to recognize that and stimulate incremental innovation in the field. Right now that is not happening, and many companies are pulling out, many big companies are pulling out of the field. And since there is such a great medical need, that would be important to recognize by society.
Now it's interesting because earlier in the first session, Nigel Darby spoke about the importance of personal medicine and how the move towards that and more individualized treatment is crucial. And I wonder, why is it so hard to reach that point of expanding on the personal medicine?
I think when it comes to brain diseases, many of the diseases are heterogeneous diseases which are based on symptomatology more than biology. And before we can get into real biological way of thinking, we need to reclassify many of the diseases based on a better understanding of the biology. And to do that, we need to understand the biology in the brain better than we do today. So it's not immediate to benefit from personalized medicines, even if we hope to have one first attempt soon.
All right, we'll touch on more of these issues as we get going. Please, again, take part with your questions and comments. Do raise your hands and we'll get the microphone to you, sir. Thank you for starting off with the questions. We'll get the microphone to you. Just 1 second. Do we have the mics handy? Here we go. Thank you. Behind you, sir. There we go. Again, remind us who you are and where you're from.
My question is to all the panelists. We were talking about partnerships to bridge the key research gaps. And reason your, one of the questions you raised the issue of budgetary allocations for research. Now, one of the great examples of partnership perhaps will be the open source drug discovery system. And in open source drug discovery system, there may be enough partners to participate. Now, why are we not seeing so much initiatives in OSDD for drug discovery system to bridge the research gap? Is it driven only by commercial reason, or there are other reasons behind it?
Interesting question, and I think a number of panelists will have to tackle this. I'm going to start with Francis Gurry first on this issue of the open source and the complications it raises.
Well, look, I think the example that I gave is an example of open source innovation. It's an example where companies do share intellectual property and unpublished scientific data, and they share it on a royalty-free basis. I would say one of the obstacles one faces is that companies have their business to go about, and they have to do that. And so we are looking at their corporate social responsibility. We're looking at opportunities for them to buy into something that is outside their immediate responsibilities to their shareholders. And that, I'd say, is the main obstacle that we face in seeing more of this. So focused arrangements that allow companies to manage their involvement, I think, are very helpful. But more generally, open source is a phenomenon, I think, which we see in the IT industry. And what's it driven by? It's driven by the availability of technology that facilitates the networking and the cooperation. And it's driven by, I think, the globalization that we see around the world. And where there is a market for it, I think we will see it develop. What we're trying to do is to encourage it where there is no market for it.
Dr. Dhaval, Patel, perhaps a perspective on this too, sir?
I have to completely agree. I think there are many examples, and you've just said one or two of them, about where this kind of sharing of information can work. However, it is a competitive world. And at least the pharmaceutical industry, we believe that intellectual property is our competitive advantage, and that's our value. And so to readily give that up is not so easy. And so we have to find models in which we can innovate in places that make sense, but continue to have our competitive advantage.
And perhaps, Dr. Mundel, I can get your perspective, and also on the issue of partnerships that our participant raised, and how those partnerships can help move things forward.
Whereas on the open source discovery proposal, I did have some discussions actually in the last couple of days with one of the major participants over here who invited us to participate in their open source enterprise, which I thought was a very interesting type of proposal, and we'd certainly welcome that kind of participation. We're very familiar with the competition in the private sector and reasons which mitigate against open source potentially moving forward rapidly. But we face the same kinds of issues in the communities, other communities that we work with, for instance, in the academic community, where there's a publish or perish type of imperative. We've set up an initiative which we call the Collaboration for an AIDS Vaccine Development. And it provides resources for people, assays, materials that researchers can access that we effectively provide to them. But the provision is on the basis that they actually sign documents that they're going to share their materials and share their information. So it's very much an open source idea, and it's actually taken off. It's become incredibly popular within the community of HIV immunologists and vaccine developers.
There's a quick question on this, because this concept of open source and the kind of sharing seems to be, and I could be totally wrong, but more a generational thing, that the sort of younger generation of scientists, the younger generation of participants in the whole equation, feel the need for better collaboration, greater openness, and perhaps a more open source attitude and approach.
I think that may be the case. Certainly we have participants across the spectrum of seniority in the field. But I think you've hit on something in terms of the generation approach to privacy, data, holding things. We've certainly looked at in other areas of data privacy and access where the count me in generation is starting to predominate.
Great, thank you, sir. Please, again, put your hands up clearly so I can get the microphone to you. I can see you, so if you do put your hands up clearly, I can get the microphone across to where you're sitting. In the meantime, I want to bring Dr. de-Graft Aikins back into the issue, and it's something, when we look at creative innovation, of course, we're looking much at the scientific approach, but you also have to deal with communities who take an approach to healing as a faith issue, as a religion issue, and give us some idea of what you've experienced in the field when it comes to trying to bring in new ideas and innovative ideas when you're up against some old traditional values.
Most people who live with a variety of diseases in Africa or Asia or Latin America, according to research, verify the legitimacy of doctors of biomedicine. So most people will say the doctor knows, best. It's best to go to a doctor. It's best to get medicines from the doctor. But at the same time, there are these competing healthcare options out there in the social world. So traditional medicine has always been available in these communities. And often you'll find, say, in Ghanaian hospitals or Kenyan hospitals, Cameroonian hospitals, that faith healers and traditional medicine herbal practitioners might be sneaked into a hospital to provide a cure for somebody who's actually been admitted for a particular condition or other. So we have these competing sort of medical strategies, and people draw on these in very fluid ways. I mean, there's no sort of cognitive dissonance about, taking the doctor's medication and taking a gallon of herbal preparations. So we have that going on, which we need to understand. Of course, there's a new wave of charismatic Christian faith healing, which is sweeping across, Africa, Latin America, and Asia. And this system actually taps into a very deep spiritual, supernatural sort of belief system, whereby, you understand that diabetes is a physical chronic condition. There's a cultural idea of chronicity, but at the same time, there's the belief that perhaps I got this physical condition because somebody bewitched me, or somebody bought this disease for me, or, somebody hates me so much that by a look, I got this disease. And so there's a constant search for spiritual meaning and spiritual sort of cure, spiritual healing from these conditions. And I think doctors in these communities, doctors, nurses, biomedical professionals, are faced with a conundrum. I mean, how do you deal with somebody sitting in front of you who truly believes that what you're going to give them works, but at the same time believes that there's something out there that might be even better and might actually cure the condition completely? And I think it requires more engagement with social scientists, I believe. I think that there's a lot that anthropologists have done in the past, sociologists have done in the past, social psychologists are doing currently, about how people think. What are the cognitive processes around why I got this disease? Why did I get this disease? Why has it come to me now? And who is actually a legitimate sort of healthcare provider? So I think innovation and research requires a multidisciplinary approach, really. I was speaking to a Ghanaian malariologist last week, and he says to me that mosquitoes in Ghana have become very ingenious because of the success of ITNs, treated bed nets. They're no longer biting people at night, but they're biting people at dawn when they wake up and, throw their nets up. So we even have to think about the ways in which, the social world and the world of insects and animals and so on, come together to thwart the best intentions of the pharmaceutical industry and the people out there who try to cure disease.
It's hard to fight nature. But also, Dr. Pécoul, I want to bring you on this, because when it comes to these challenging environments, there's also not only the developing world where perhaps traditional views and faith healing complicate the issue of trying to innovate and bring in new practices, but also conflict areas make it difficult for you to approach people who are perhaps inaccessible because of the difficulties there. How do you approach that when you're trying to deal with these neglected diseases?
Of course, we have selected diseases that are quite complex because our top priority is sleeping sickness, so concentrated mainly on the central part of Africa, and second priority is leishmaniasis, also very prevalent in eastern part of Africa, so with a lot of instability, with people living in very remote places. But as I mentioned rapidly in the introduction, I think the key to make progress is to start from the needs. And when I say starting from the needs, it's not a theoretical comment. So we need to discuss very early on in the process with the communities, with people involved in managing cases to understand very well where are the obstacles, where are the difficulties, because you cannot develop a technology only based on the science. It's not enough. You could have an excellent treatment with excellent results within the scope of a clinical study that could not be implemented. So what is very important is to adapt your, what we call a target product profile to the very specific needs of the population and the capacity to deliver at a village level. Because I've always in mind this village level. For sleeping sickness, for example, and we discussed yesterday with Trevor, what we need is a very simple diagnosis that could be implemented at a village level with a short course treatment. And with such a tool, we could eliminate a disease such as sleeping sickness because the population is very conscious about these diseases. It's a fatal disease. When the disease is prevalent in a village, you have a very high level of mortality after several months of mental health disorders. So with a lot of stigma. So it's not difficult to convince the community.
Thank you, sir. You know, what we did do was also approach the World Health Organization to contribute some comments here. And we have a couple of video clips from Dr. Marie-Paul Kieny, who's the Assistant Director General of Innovation at WHO. And this is where she talks about the issue of gaps that exist in research. So just watch this quickly.
A key research gap today relates to the development of effective intervention to treat conditions that are burdensome to developing countries, particularly type 2 and type 3 diseases. One reason why there has been insufficient research in this area is because the commercial value of intervention to treat these conditions still tend to be small, resulting, of course, in limited motivation on the part of private industry to make the necessary investment in research and development. While some interventions exist that are effective in a developed country context, these may not be effective in developing country setting. Funding is a significant barrier, and a concerted global mechanism is needed to provide support not only for the research component, but also for the development, testing and manufacture of these interventions. Recognition by developing country governments and their neighbors that the investment to address this condition generates value through having a healthier population is essential.
It's Dr. Marie-Paul Kieny there of WHO. And Wiinberg, I want to put this to you. I mean, it's true, she did put a little slap out there saying that if there isn't the financial incentive, companies might think twice, but also mentioned the need for better cooperation and better research into where the gaps are. And I wonder how your company fits into this and how you see it progressing based on some of these comments.
I think when we look at early stage, we have a European collaborative effort called IMI, where we're trying to share IP in a more open way and finding new ways to making research cheaper and better and use know-how. I think we want to also work with different healthcare delivery systems to show the incremental value of new medicines in actual use, which is different from the regulatory trials that we are traditionally doing. And I think in general we are keen on trying new ways of working together to improve outcomes.
And I know you feel that there is a need for a more holistic approach, that if it's simply the drug, and that's, as you say, 97% of the treatment, then it's not really effective.
Yeah, I mean, if we look at mental health care, if you, for most of the diseases, depression, epilepsy, ADHD, if you have an early successful intervention, people live a normal life. And clearly, most of the cost when it doesn't work comes outside in terms of lost productivity or impact on the carers. So we can see with depression that maybe 60% of all the depressed people are in the workforce, and when they are treated well, they have a normal life, a normal professional life like everyone else. When they are not treated well, they fall out and end up in long-term sick leave and early retirement programs. So clearly working with employers and other stakeholders and finding out, okay, what can drug interventions do to improve the outlook? But there are also many, many other things that you can do to ensure that you address depression at the workplace early on to ensure that people stay successful at work.
Thank you, sir. I'm going to get a microphone to Eduardo Pisani. And as we get the microphone... Oh, you have it already. Okay, there you go. You beat me to it. Please.
If anyone in the panel had to name one incentive and one significant hurdle to innovative solutions, whether in research or in services, what would they be? Thank you.
Okay, Trevor Mundel, okay, Ulf Wiinberg first, then Trevor.
Just to build on what I said before, if you can include societal costs when you do health technology assessments, that and also find different methodology where you allow actual use studies to come through at a greater extent, then you would encourage more innovation within mental health and have more companies engaged in it, which would eventually lead to us having disease-modifying drugs in this field too.
And Dr. Mundel?
Well, I guess on the incentive, it's more, to my mind, a matter of communication. You saw the huge portfolio and the massive impact that this would have on global health if people truly understood that. So I think the incentive is a communication issue. In terms of obstacles, we've heard a little bit about that. We heard from Murray Paul Keeney at the WHO. I think a good, consistent framework for international regulation would help us tremendously. And know that the WHO has now picked up the cudgels to take this on. But I think the industry has a big role to play in terms of contributing to this effort.
Thank you, sir. Francis Gurry, if I can get your perspective on this too, as we get a microphone to our next participant.
Well,
please tell us.
Let me focus on the obstacle, if I may. I think one of the obstacles is old habits die hard. And we're living in a world in which change is extremely rapid, and change affects innovation in many ways. We've had open source innovation mentioned, open innovation generally. The geography of innovation is changing. The competitive stakes are changing. It's becoming much more, innovation is the battleground for competition to a much greater extent. So all of these factors are producing a very fluid environment in which I think it is much more difficult to focus on results. So that's the big obstacle, is the uncertainty of the environment in which we live, I'd say.
Thank you, sir. Our next participant, tell us who you are, where you're from as well.
Thank you very much. My name is Gerald Jekan from WHO. I would like to bring back the discussion to the point of open resources and the need for collaboration and partnering to
Sorry, hold the microphone a little
innovate.
closer so we can hear you. Thank you.
Partnering to innovate. We have heard from Dr. Patel that competition is probably one of the main barriers. And so in these areas of market failure, or maybe I should say in areas where the incentive structure is not lined up to support private sector innovation and research, so isn't it time for the public sector to take on the research? And I would like to stress one example, and that is antimicrobial resistance. Not an NCD issue, but here we see that there is a market failure, if you will, in the development of new antibiotics. So isn't that time for the public sector, and what is the prospects of that? And if I may add one other aspect or one other question to addressing research gap, is that we have not discussed yet a lot about delivering systems and how to maybe address the issues there, and that is the irrational use of drugs, the inappropriate use of drugs, which very often is caused in behavioral structures, misinformation of patients, And AMR again is a good example of that, but can be extrapolated to other disease areas as well. And is there research ongoing, and or should there be more research in the area of changing behavior on the consumer end? Thank you.
Okay, interesting point there. I think, actually, Dr. Patel first, and then I'll come to you.
Sure. So I fully agree with you. I see two different areas. The places that are non-competitive in a way, and that seems to be the communicable diseases of the developing world. I think you see people on the panel that are in that space, and we all actually work together. We have activities with the Gates Foundation, also with DNDi, and others. I think that that is a place that you see this working. The places that is still a challenge is the non-communicable diseases, which are, in fact, diseases of the Western world also. And that's the difference, and this is what we discussed earlier, is how can we set up a model in which we can continue to have protection of intellectual property in a meaningful way that you can continue to make money in the end. This is essential. We can't have these other activities that we're talking about if there's no money in the system or resource in the system. So how do we continue that resource?
And I know, Ulf Wiinberg, you wanted to add something to that too.
Just a comment on antibiotics. I mean, in the mid-90s, most multinational companies did antibiotic research. But if you were in the business of antibiotics, you were considered not a good social citizen because you were not doing a good thing. And that feedback was pretty consistent, so most companies kind of gave up in the mid-90s. And you can say the challenge is how do you encourage somebody to develop a drug that you shouldn't be using unnecessarily? And somehow that we see the effects of that discouragement today in the lack of new antibiotics. And I cannot help myself by drawing the parallel to the mental health area, because today we see the feedback is that there is a lack of need. We don't want to pay for incremental innovation. Many companies are pulling out. At the same time, the healthcare need is so big. So you can see a similar reaction within 10 years, for instance, in fields like depression too.
All right, Dr. Pécoul, you wanted to add something?
Yeah, I wanted to react to the question to bring back the research in the public sector. I'm not sure that is exactly the issue. The issue for me is more a question of leadership and setting priorities and putting in place the environment to facilitate. When we had a discussion on open innovation before, I think I strongly believe that we need to be move more into this direction, but with something that is organized by the public sector. Because I think, and things here are moving. I want to refer to the CEO of GSK, Andrew Whitty, since now 18 months, is claiming that he wants to move in this direction. Recently, set up a conference with a Wellcome Trust. They're saying we need to go much further into this direction, but I think it will be necessary to have rapidly the conditions that need to be created. First, probably through pilot project. So learn through example, and I will say that the field of neglected diseases is probably an excellent field to test the example. Maybe antibiotics is a second example. So I think the leadership from the public sector is key.
And you actually raised an interesting point, because that was part of our participants' question on the issue of the public sector. And Dr. Aikins, I wanted to ask you about comment on that and what you see the policymakers doing, certainly in the area in which you work.
Yes, and I wanted to comment also on the behavior change idea. I mean, when experts talk about irrational use of drugs, it's actually rational in the world of people who live with illness, who live under very difficult psychological, social, economic circumstances. And so what we really need to understand is what rationality and irrationality means in the life of somebody who lives with a condition, mental health condition, an infectious disease of poverty, or a chronic disease. we know, for instance, that people spend very limited time with their medical professionals and spend much of their time treating their illnesses in the social sphere. And I think one area that gives us a really important model to be HIV/AIDS care. For instance, the way in which finances have been amassed around HIV/AIDS care, whereby, for instance, you have people going to see their doctors, but also having a whole sort of care support system outside in the social sphere, helps them to adhere to medication. It helps address issues around depression. It helps address issues around poverty and disease, poverty being a driver and outcome of disease and so on. In terms of what health policymakers are doing, for instance, I mean, I know that there's been an international network for the rational use of drugs, which has been around for quite a while, and it operates in a number of countries, not just in high-income countries, but low-income countries. And they have worked with governments, health ministries, for instance, to look at how prescribing habits might change and how this might cascade down into how everyday people use their medicines and so on. I think, again, this is a model that is very useful. Another network that's been developed very recently is META. I think it's called the Medicines Transparency Alliance. Again, very sort of interesting sort of collaboration of a variety of institutions, global institutions, which seek to understand how, low-income governments might be able to leverage whatever power they have to get the drugs they require for the myriad of diseases they have in their countries. So, yeah.
Thank you. Well, let's hear what Dr. Marie-Paul Kearney had to say about how the gaps can be addressed, having raised already what the gaps are. Here's another video clip of her.
Industry and academia already have much of the technology that is required to address these conditions, including, among others, chemical libraries, pathogen strains, and gene sequences. However, there is an urgent need to strengthen R&D capacity of developing country institutions so that scientists from the South become full partners on this research. The testing of many new interventions needs to take place in developing country populations, for which country-level capacity may be a limitation today.
Okay, there we hear for the World Health Organization again. Let's get our next participant in with the microphone there, sir. Thank you again for your question.
Yeah, thank you very much. I wanted to ask a question. We spoke a great deal about partnership and the grouping and so forth. Now, the world is still divided into great language empires. The Francophones, the Hispanophones, the Russophones, the Anglophones, the Saxophones. I mean...
And they all now have mobile phones.
That's right. What we have discovered in the course of time is that it's extremely difficult to work between those sectors because the way of thinking, the language structure, the traditions, the schooling, the recognition of diplomas, everything is different in these different places. And when we, in a country like Africa, if you look at east and west of Africa, or Francophone and Hispanophone, etc., I mean, a really major difficulty. I wonder to what an extent this has been harming or making it difficult to establish partnership, not only at the level of the top people who talk to each other very well, and many of them are multilingual, but going down, trickling down, and applying whatever is being done. Is there research in this? Do we think about it?
Let me put this first to Dr. Mundel, because you work at a global level, and I wonder how much this actually comes in to complicate what you're trying to do in building partnerships.
No, it's a very interesting question, and we do see that working out in some areas. Take, for instance, investments in healthcare in Africa from a country like Brazil. And Brazil has chosen to focus a lot of the investments in those countries that it shares some cultural heritage with. So it's been Angola, it's been Mozambique. The same has been for Francophone West Africa. So it is a reality on the ground that in the developed countries or the emerging growth countries, their association in Africa in particular has been with their cultural heritage.
It's interesting. I don't know if anyone else has a perspective on this, because I know, perhaps Francis Gurry can.
Yes, let me just add one point, that now, for example, if you use patents, international patent applications as a measure of technology production, about 38% of the world's technology is produced in Chinese, Japanese, and Korean. So But there are ways of tackling that. I think there's great advance has been made in machine translation. There are various ways to deal with disembodied, if you like, technology. But I think your question goes to personal relationships and how much language is a barrier in that context.
We had another hand up, and I was waiting to see where is it? Ah, there we go. Thank you, sir.
Can you hear me?
Yes.
So I'm Surendra Gokhale, working from Hoffmann La Roche in Switzerland.
A little closer to you. We need to raise the volume a bit. But
my question is raising one more point for the discussion. It's about the prescribers and healthcare providers and how much time they have to inform patient or who is approaching them about their disease, but also comorbidities and some other parts. And we know the limitations, but is there a way for innovation there to have latest information? And there is a lot of information available, but it's only available for the people who have access to it.
Right.
So can we do something around that to really improve the information exchange using some latest technologies, and also for the compliance? And one quick example, I think it was a project founded by Gates Foundation. One of my colleagues from the company was working on it in Ghana. I don't have a lot of details, but what I heard was there was a simple technology where patients were reminded about taking their drugs by probably a color system, and when they have completed their course, there was a different color system to select for. Maybe even successful projects like this, we need more information with different people so that others can use it.
Let's get a perspective from two panelists. And Dr. Pécoul, first I'll start with you, and then Amma, if I could come to you, Dr. Aikins. Sure. The issue of using innovation to increase patient compliance by getting information out to them and communicating better with them, especially you're giving a developing world environment issue. And I wonder perhaps, Dr. Pécoul, and get your perspective first.
Okay, I don't have a lot of experience, but what is obvious is that today the mobile phone is everywhere, and we can use it. We use it to follow patients during clinical studies. We can use it to monitor the stock of drugs in different settings. So I think it's an opportunity that we have. According to me, it's much more easy to imagine this sort of program now with what is in place, and you can go to. I visited some very remote places in Republic Democratic of Congo. You have no problem to use your mobile phone. So I think it's an opportunity, and it's a little bit the same on the previous comment. I think today we have. In our model, in our partnership, we think we are no more thinking north-south. It's the end of this model. We developed a drug combination for malaria. Our first industrial partner was in Brazil, the second one was in India. All the clinical studies have been implemented in Southeast Asia and in Africa. And the people have been working together in a very good relationship with no major delay. So I think, according to me, I'm much more optimistic on the possibility today to have a much more interconnection between populations.
All right, Dr. Aikins, a quick thought, then Dr. Mundel, I'll come to you, but first a quick thought.
Three interesting strategies have been employed in Ghana, for instance. Medical professionals have tried to use the mobile phone, for instance, to help pregnant women access care and follow-up care, with their healthcare professionals. Very recently, a Ghanaian entrepreneur developed a system whereby rural and urban people who may be using counterfeit medicines could call a number which would allow them to verify whether the medicines they had were legitimate or counterfeit. And also in a place where usually health promotion professionals are very, very low on the ground, very interesting strategy has been malaria professionals essentially training the media personnel on how to report on malaria, the course of malaria, complications of malaria, the various treatments out there. These are all at pilot stages, but I think they're very important models that can be adapted by other countries.
In fact, I met a very, very smart young, I think it was Ghanaian man who developed a system to avoid counterfeiting, where it was a text message, a scratch off.
That's Bright Simmons.
Bright Simmons, that's it. Dr. Mundel, you had something to contribute here.
Yes, the questioner had mentioned one of our programs. Right. I was a bit concerned that this might be somewhat of a fad, and what would be the actual impact, and had the opportunity recently to visit some of our field work in Bihar state in India, which is a state with a large population and poor infrastructure.
Much, yeah.
And pretty amazed at some of the programs that are ongoing over there, and actually now quite convinced that this is going to be impactful. one cell phone-based technology to back up non-traditional healthcare practitioners is a number that they can call if they're confronted with a confusing case, which they're not clear about. And they guaranteed access to a physician within a very short period of time, can speak about the case, and can even have the potential patient directly communicate with a physician who's sitting in Delhi. Other in village program we have on telemedicine, have more than 1,000 centers where there's a telemedicine presence in very poor villages that people come to, and they connect by a video link, low quality video link, to a team of physicians in Delhi and get their diagnosis and their treatment out of that. So I'm very bullish that this is going to actually be an impactful intervention.
Yeah, I've seen an interesting demonstration of Cisco systems where they can do remote and simultaneous translation too, which is very interesting. Actually, the issue of communication has sort of come up as we wrap up this panel, and it always reminds me, the issue of the public sector and getting a straight answer from politicians comes up a lot, but also the issue of languages. And I'm reminded by a story that Sir John Major, the former British Prime Minister, always tells of a visit to the Kremlin he made to see the late Russian President Boris Yeltsin. And he said, I thought I'd test him with a question, a tough question. So I said, could you describe the economy of Russia in one word? And Yeltsin said, good. I said, how can you say that? I thought it was falling apart. Okay, if you could use more than one word, what would you say? And Yeltsin said, not good. So getting a straight answer is not always easy. Please, a round of applause for our panelists here. Thank you so much.